So I'm Dan. I do pediatric palliative care at Texas Children's, and we're going to talk about values and decision making today. All right, so briefly starting with the humanities side of this, where do values come from? Where do we get our values? This is a very interactive talk, so you guys are only going to get out of it what you put into it.
Religion.
Was it religion? Okay, great. Where else?
Family.
Family.
Culture.
Culture.
Intuition.
Yeah. Intuition.
Upbringing.
Upbringing. Excellent. Where else do values come from? Awesome. How do we express those values? Yes?
How we spend our time.
Okay. Time, yeah. That's a valuable resource.
And money.
And money, another valuable resource. Maybe not as valuable as the first one. How else do we express our values?
Policy.
Policy? Okay. How else?
What we choose to study.
What we choose to study? Yeah. What else? What's that?
And art.
In art? Yeah. What we're devoting our artistic time and money and attention and creative energy to. Traditions. Maybe particular rituals associated with our family, our culture, our society, our upbringing, things like that. A variety of different ways that we express our values. So now I'm going to pivot now from thinking about values to thinking about making decisions, because we've talked about expressing our values in terms of how we're going to use our time, how we're going to use our money, how we're going to use our creative energies, things like that. How do people, how do human beings make decisions? Like, what is the actual process going on there? How do we decide things?
Your instinct.
Instinct? Okay. Yes?
Input from others.
Input from others? Okay. How else?
We weigh options.
All right, weighing options. Yeah, like the scale that we have on our brochure. What else? Yes?
Considering consequences.
Okay. So as part of the weighing of our options, considering risks and benefits. Great. What else? What about the way that something is presented to us? You think that impacts the way that we make decisions? The frame of mind that we might be in, our emotional state when we hear information that we have to make a decision about? A lot of those things that will impact our decisions. In addition to everything that you guys said, the amount and type of information that we're given about a particular topic or about a particular decision, that will impact the way that what we decide. So traditionally, we've sort of modeled our decision-making in healthcare on this rational utilitarian sort of idea that, the more information that we have to weigh the risks and benefits, that's the way that we're going to make our decisions regarding our health, our safety, our security, things like that. In the last 30 or 40 years, there's been a lot of work in behavioral economics. If you guys heard of behavioral economics, raise your hand real quick. Okay, so people are familiar with it. We are predictably irrational, and we rely on our instincts. We rely on our emotions a whole lot more than maybe the rational utilitarians think we did when they built some of these decision-making systems. And that's kind of what I want to talk about today. So we've got two cases we want to talk through. We have a family of a child with a life-limiting illness. So let's say a widely metastatic, incurable cancer. They value life prolongation above all else, and they want a tracheostomy, which is a hole in the neck that connects to a ventilator, so that a patient whose lungs are not working anymore can still continue to breathe by having the machine breathe for them externally. So they want a tracheostomy to support breathing with a ventilator at home. But the medical team disagrees with placing the trait because they're worried that the patient, this child, is going to be uncomfortable and have a poor quality of life. Okay, so we have a couple different sets of values at play here with this decision. Which value should we rank higher? The life prolongation that the family is advocating for, or the comfort that the medical team is advocating for?
What do they mean by poor quality of life?
Great question. Who gets to define what quality of life is? I would say, oh, go ahead.
In most cases, shouldn't it be the patient? In this case, since it's a child, the family also has a say in that.
Yeah, I completely agree with that. I think that the definition of quality of life belongs to the person whose life it is. And if it's someone who can't say that for themselves, like in this case maybe a young child, then it belongs to their parents. And that's sort of where the ethical decision-making paradigm rests right now in modern medicine, is that value-based decisions kind of rest with the family. But what about the medical team who has to do something to this child that they think might cause additional suffering or maybe prolong a life that is uncomfortable? What do they do? You guys jumped ahead of me on that. Hold on. Yeah.
I guess I feel like the medical team, like one of the values of the medical team should be the autonomy of the patient.
Mm-hmm.
So maybe more than dictating what the patient's values should be, respecting the patient's wishes, even if they don't necessarily, like, I guess making it clear what the trade-offs are, but at the end of the day, I feel like it should be the patient's decision, and that should be respected by the medical team.
Yeah, so respecting the patient's autonomy, giving them the information, letting them make the decision that's right for them, for their family, letting the family decide what quality of life means or what comfort means. And then ultimately, it's the family's decision, and then the medical team, they're in the position of just sort of responding to that and helping tailor interventions to what the family's decision is. Okay. Other thoughts about this case? Any other difficulties or challenges that you see with the intersection between values on either side, or competing values, decision-making?
Are there any legal considerations?
Legal considerations, like what? About which part?
Like, would there be some kind of malpractice if they didn't extend the life or something like that?
Nope.
Oh,
Nope. Excellent question. So in the 1980s, there was a law passed that was called the Baby Doe Law that said that any child with a life-limiting or terminal illness, it was completely within the parental rights for that child to not want to, or to make a decision that did not prolong their life, if that was not in keeping with the family's values. And so there is a sort of ethical legal protection there to not have to prolong life in settings where there may be this discomfort or poor quality of life that's defined by the family. All right. So we're going to switch things up a little bit. Another family, child with a life-limiting illness, tells you that they value comfort and time at home with their family over aggressive ICU-based medical interventions. So what they value most in their child's illness and life is being at home, being surrounded by family, not being in the hospital. So a medical provider suggests a second trial for the treatment that was ineffective the first time. And the family chooses that treatment, even though it means more time in the hospital and less time at home. So let's say that you're one of the clinicians to help take care of this child and their family. What is your role when a family chooses a treatment that's not in line with their own stated goals? So the family told you that the thing that they value above all else is time at home. and the decision that they make is something that is going to keep them in the hospital, and it's a treatment that didn't work the last time they tried it. What do you do as the provider? Yeah.
I guess to remind them of what they said their goals were and try to explain how this new decision may or may not fit with those.
Okay, yeah, so sort of highlight that discrepancy to them. Yes?
Like, how much is known about like this trial? Is it like the exact same as the first trial?
The exact same as the first trial. The first trial didn't work.
So do they think it's just like a fluke that it didn't work the first time?
I don't know. There was another clinician who proposed trying it again. They thought that there may be some benefit in giving it a shot again, even though it didn't work the first time. But it was convincing enough of an argument that the family decided that they would go with it.
They should provide them with all the information so they can make a balanced decision.
Okay, provide them with information. Information like what?
Like educate them on the treatment, the chances of it working, and what that means for them, and that it wasn't a mistake. Just make sure they understand the implication.
Okay. All right. So extend some of that informed consent about this treatment trial. What else? Yeah.
Perhaps coming back to those values that have already been discussed, because they can change.
Yeah. People are entitled to change their mind. They say, you know what? Yeah, I realize that I told you this before, but this person made a really convincing argument that this time, this trial that didn't work last time is actually gonna work. So, we're willing to give it a shot, even though it's gonna mean that we don't get to have this value that we said was most important. Yeah. What else? Okay. So let's talk a little bit about ethics. Where's the ethical weight and the weight measured here? More ethical to allow someone to make a decision that won't achieve the goals that they desire, or to review but not recommend the treatment options, or to review but not recommend treatment options to only those which will meet the goals that the patient desires. So that's, I confused myself reading that out loud just now. I probably should have done that before making the slide. So let's say options are, you just say, okay, this is your decision, even though it's not meeting the goals that you said that you have. It's your decision, patient autonomy, whatever it is that you want, that's what you can do. And the other option is to say, hey, these are the different options. I don't recommend it because this is what you told me your value is. But this is the information on all the things out there. Like, yeah, we tried this before, it didn't work. Just to remind you of that. Is there an ethical difference between those two stances? Are they ethically equal? Are there other issues at play? What are your thoughts? Yeah.
In the second case, it seems like the physician is playing a much more active role in the decision-making process.
Okay.
Whereas in the first, there's definitely a, emphasis on physician autonomy or patient autonomy as the, principle at play.
Okay. All right. So yeah, that's one key difference is that the physician or the clinician is much more actively engaged in the decision-making process in the second one than in the first one. Okay. What else? Yeah.
You mentioned framing effects earlier, so
Okay.
I think we should be skeptical of any approach that aims to just sort of objectively lay out all the options, because it's really hard to just give pure information.
Is it possible to completely objectively lay out all the options?
Probably not.
Yeah. Go ahead.
Like, how much do you personally think physicians should put their own opinions into presenting the decision-making process, like their own experiences and things they've seen before presenting to try to educate the patient on this?
Excellent question. I think that there is a balance that can be struck between the paternalistic ideas of maybe the first 2/3 or so of the 20th century. And then maybe the extreme of patient autonomy, where whatever the patient wants, whatever the patient says, whatever's going to increase patient satisfaction the most, that sort of end of the spectrum. I think that there's a happy meeting point somewhere in the middle there, where the patients can provide the goals, the values, the things that are important to them. Physicians can participate in the process and say that, you know what, I went to school for a really long time, I did training for a really long time, I've seen a lot of cases that are very similar to this, so this is my recommendation based on what I've seen happen before, and I think that offering that personal recommendation is actually a really important, integral part of what it means to be a clinician. And so I think that there's a wide variety of, I think, clinical providers that are all across the spectrum. That's kind of where I land on it. Other questions? All right. So like I told you, I only had like 5 slides. Medical decision-making is hard. Modern healthcare assumes that rational utilitarian decision-making is what we do. Unfortunately, we're rarely rational or utilitarian, especially when making decisions about their health, and even more especially when making decisions about the health of your child. So parents have a whole bunch of different added layers of surrogate decision-making and narrative and moral identity issues that go into being a good advocate, being a good parent for their child, that go into influencing their decision about their child's health. So the current ethical best practice is something called shared decision-making, which is what I was sort of describing before. So it's where you recognize that a decision needs to be made, the patient provides the goals and the values, and the clinician provides the treatment recommendation that'll meet those goals. And something that comes up in pediatric palliative care pretty frequently is that the stated goals, there may not be any treatments that will meet those goals. And then we have to identify, well, what are some other goals and values? Or how can we be creative with treatments, and what are some other risks or other things that we're willing to accept in terms of treatments that may be outside the box of what is normally offered to try and meet the family's goals or values. Yes?
So are you supposed to do that third bullet without making any value judgment on those goals? So what if the family provides their stated goals and you find them superficial? You still just meet the goals with your recommendations?
Tell me what you mean by
Finding superficial.
finding them superficial.
I mean, there's some stated goals that align with religious values that we
Okay.
don't identify with
Mhm.
whatsoever.
Yep.
Like a Jehovah's Witness doesn't want a blood transfusion.
Okay.
Is, I guess, the example I can think of. And you find that like value unrealistic or
Mhm.
whatever. You still only provide like options that align with that value?
Yes, so I think that if someone has a value that is not something that is so far sort of afield of what is ethically accepted as normal, that I tend to give patients and families and children a whole lot of leeway. If they say that they value something and they say that their faith tradition as a Jehovah's Witness says that they can't get into heaven if they receive blood products from someone else. And I say, okay, I see a situation where we may have blood products or the need for that coming up in your future. What if we do something like take out and save some of your own blood now so that it can be given back to you in the event that that comes up. So there can be creative ways, like I said, to kind of work around this issue, but I will almost always give the family the leeway when it comes to stating their goals and their values, because they're the ones who have to live with the decision for the rest of their lives. That's especially with regard to something that is faith-based like that, and I'm not going to inflict existential and spiritual suffering on a patient or family for the rest of their lives because of my own professional belief that, oh yeah, it's totally fine to get a blood transfusion, we do it all the time, there's no problem with it. But I'm not the one who has to live with that existential and spiritual suffering then for the rest of my life. Yes?
I have a question. In geriatric care, what do you see are the implications when there's like an inheritance on the line or something, and the patient can make the decision, so it's their family.
I do pediatrics. I don't, so. One, adults are just kind of gross to take care of. And two, I think that situation comes up, but not maybe as frequently as, you know, ethicists or policymakers will tend to portray it. I think that having a multilateral conversation with the different members of the family, the patient, the provider team, can often help identify when something like that might be taking place, and it can also help identify what the best way to secure the best thing for the patient is, by just making sure that everyone's kind of on the same page as you go through the decision-making process. Good question. Yes?
In pediatrics, what do you do if not everyone's on the same page? Like mom disagrees with dad, or the child voices an opinion that's different from the parents?
Excellent question. So for mom and dad not being on the same page, probably easy to presume that happens all the time. Mom and dad are totally different people. They may come from totally different personal, cultural, spiritual backgrounds, and so they value things differently. Even the way that they perceive their child's illness can be very different. And so what we'll do is sit down and have a conversation with them and say, look, this is how this parent is perceiving what's going on. This is how this parent is perceiving what's going on. This is what we perceive clinically is going on. So how can we all come up and create a narrative that works for everyone, that we can all sort of agree on is where we're going to make decisions from. Most of the time, we're able to sort of broker that difference. Every once in a while, it'll be very, very extreme, and then the default tends to be to agree with the decisions made either by the parent who has had the most personal, intimate knowledge and experience there at the bedside with the patient, or in the case of a family separation, whoever it is that actually has the legal custody and guardianship. When it comes to integrating a child's point of view, if they maybe have a different perspective than their parents, ethically we use something called the rule of sevens. So the patient is under 7 years old. We just assume that whatever the parents, say and sort of project their values onto the child for decision-making purposes. We'll just assume that the child is going to fall somewhere in line with what the parents say it is. Between the ages of 7 and 14, that's where a child starts to develop sort of their own sense of identity, and so it becomes more and more important to incorporate the child in sort of the decision-making process. That's the age range where it can be very, very difficult to even have conversations to share about true clinical trajectory or honest information if parents want to protect their child from what can be really messy, really scary information. Over age 14, from 14 to 18, the patient's assent is considered to be really important and vital to the process, because they're at an age at that point where if they don't agree with it, they are often big enough to say, no, I don't want that, I'm going to pull out my IV, I'm going to do all these other sorts of things to not participate in the care that I don't want. And so getting their perspective and their buy-in in the whole treatment process becomes much more important the closer they get to that age of majority at 18. Does that help? Okay. How am I doing on time? I think I have like 1 or 2 more minutes. What other questions? Yes?
So how do you kind of destigmatize palliative care when presenting it as a care option, especially when we're like such an intervention-heavy society?
Okay. Palliative care has a stigma? What stigma does palliative care have?
Like I guess like the stigma of like failure on the part of like the family, or like they're not doing enough.
Okay. The family failed, and that's why someone is dying,
Or like by turning to palliative care as opposed to another like more invasive option, like
giving up.
yeah. Is it a stigma?
Totally a stigma. I'm just messing with you. I'm
Okay.
sorry. Totally a stigma. Yes, absolutely. There's this idea of giving up, throwing in the towel. You're not doing everything that you can to be a good parent for your child if you accept the idea of palliative care. And I will tell you guys the same thing that I tell every family that I meet. Palliative care is an interdisciplinary team that provides an extra layer of support to families of children with chronic or serious illnesses. It has nothing to do with whether the child's going to live or die. It has nothing to do with hope, giving it up, trading it for something else. None of that stuff. And so I think the concept of palliative care as giving up and throwing in the towel and so on is something that actually comes from other medical providers that they project when they explain palliative care to families. That is where that idea comes from. There was actually a publication that came out a few months ago that actually showed just this, that most patients and families have no clue what palliative care is. People know what hospice is, and that's a small circle of the big umbrella of what I do in palliative care. But when it comes to actually explaining palliative care, most people are clueless, and it's providers that actually provide that stigmatization and narrative. And so it's really educating our colleagues to sort of explain palliative care in a less threatening, less stigmatizing way. Good question. All right, I'm over time. Thank you guys.